This is the recording of today's presentation with addition of comments and feedback made during the session. Today I will be presenting about and shoulder conditions that are prevalent among workers in the occupational and environmental health clinic setting. With regards to presentation outline, I want to start with shoulder anatomy and structure and how to do physical examination. I would like to go to a case presentation afterwards and what are the differential diagnoses to consider with these presentation and overall management and how to manage from work capacity and hazard management point of view. Shoulder anatomy is the ball and socket joint, synovial joint. It is one of the most mobile joint in our body, and it has humerus, scapula, and the articular cartilage, as well as clavicle. By itself is that it's very unsteady and unstable, so we have other structure that add stability to the structure itself. So they are in terms of ligaments and muscles. So we can see that they are glenohumeral, 3 of them, and coracohumeral, coracoacromial, and transverse humeral ligaments. They are important. And from the rotator cuff muscle, they are one at the back. In terms of that will be infraspinatus, teres minor, and subscapularis. And on the side is deltoid. On the front is the pectoralis major. Among all of them inside there is a subacromial bursa and subdeltoid bursas. They are important for stability. So the labrum, joint capsule, and ligament provide static stability. Rotator cuff, pericapsular muscle, and the long set of bicep provide dynamic stability. In terms of the David commented that I should also include what symptoms that we would expect from the condition. So that I would say there will be shoulder pain, there will be history of either traumatic or atraumatic shoulder injury, and then maybe that time may be acute onset or subacute onset or chronic onset. They all can present to the workplace. Or there could also be a fall. So past injury history is important, as well as their medical history. If we are looking at the shoulder examination, we follow with the inspection, palpation, movement, and special tests. So here we can see that we look at good consent and good exposure, and we have to look at from the front, from the side, from the back, and the scapula. David also suggested that to check the scapulohumeral rhythm by moving the arm to the side. That will be included in the assessment. In terms of the next step, we will go to palpation. Palpation is that we have to check all the component of the shoulder that we can check. We can feel the muscle bulk, the joint ligaments as listed there. Unfortunately, this is also not very sensitive to the pathology. For example, someone can have anterior shoulder pain. Many conditions can present with anterior shoulder pain. It is not just unique to supraspinatus tear, for example. So after that, we ask people to move from active and passive movement. So active movement is we have a lot more range of motion in the flexion and the abduction, whereas extension and adduction had limited motion. If someone has pain with the external rotation and reduce, and that could be an indication of the adhesive capsulitis. After that, we'll go to the special tests. We have 4 different categories, and the first is the impingement. Now you can see that in the picture in the slide. Let me see. So you can see that the Neer test and Hawking-Kennedy tests are 2 most commonest tests we do. We need to do all of them in a thorough fashion in exam, and we need to be able to comment how good their sensitivity and specificity are. And I wrote down in a range, and that depends on what research study were published. So you can see that you're not going to memorize a single digit or value for each test. You have to comment that in a ballpark figure. So that will tell us if there is any shoulder impingement syndrome. But in other tests, I'll also be positive. The next step is we need to check if the rotator cuff itself is there any tear or any problem. So we'll do empty can tests, drop arm, lift off tests, and belly press tests are useful, and we need to demonstrate that in the exam that we can do them. Personally, I do myself empty can and belly press tests. I don't do the drop arm and lift off tests. And stability test is that apprehension and relocation tests. These tests have relatively low sensitivity. However, if it is negative, their specificity is really good, as you can see, 0.96 and 0.92 here. And the final bit is that labral or bicep pathology. This is for testing if there is any tear within the labrum. Now we can see that there are 3 tests I mentioned, so we need to be able to demonstrate that in the exam. Alright, so after overview of the shoulder examination, I want to go on to the case. So this is a case of work injury that seen by my colleague first, and then I look after her when he was away. So this is Rose, 63 years old female worker. She presented to the clinic with 2 weeks history of right shoulder pain, and there is no history of injury, and the pain is restricting her movement, affecting her quality of life at work and outside of work, and it is affecting her sleep. Her job role is that a cleaner or bin collection driver, and she's working full-time for the last 7 years. She had presentation with similar issue last year on the left shoulder, and this is the right shoulder. Last year it resolved itself with conservative management over 2 to 3 months time. Past medical history wise, hypertension, depression, and current smoker. David commented that we should include diabetes since it can be associated with adhesive capsulitis, and medications like candesartan, dexlansoprazole, and sumatriptan for occasional migraine. So this is based on the initial notes from her presentation. She looks well, and there is appropriateness for her mood and affect. Shoulder range of motion is that normal alignment, no deformity, but there was tenderness on the anterior and at the side of the humeral head. In the movement section, she has limitation with abduction and the flexion, so that there is problem with the painful arc, and the document suggested that she was positive with empty can tests on the right side, but normal on the left side. And she was sent away for having an X-ray and ultrasound scan. X-ray can show if there is any bony abnormalities, and ultrasound can show if there is any dynamic problems such as pain or impingement during the assessment, or if there is any tear. But it may also be absolutely normal as well. So when I saw her 4 weeks later, she already seen a shoulder specialist, which I come in later. She still have painful with the movement. However, she can move all range, and when I do the palpation, there is no tenderness, and when we do the empty can test and the Hawking Kennedy test, when we do that, there is still mild tenderness is detected. So she was managed with modified duties and physiotherapy as predominantly, and she's also similar opinion from the orthopedic specialist that we rather do the conservative management and try that first, considering it was a short-term or symptoms or duration before the problem. Over the time, we see that her physical capacity improved, and as of last week, she can lift up to 15 kilo both hands at shoulder height and 20 kilos at hands at the waist height. Her initial presentation was from July, and this is in early November. So my plan is to allow her to return to her work capacity. There is also another issue of work is concerning about her being a 63-year-old doing a physical or manual labor job, but I commented that this is not related to current injury problem. So in her case, my diagnosis is that even though it is supraspinatus tear visible, it may well be incidental finding. So what is the diagnosis with her? We can say that she has shoulder impingement syndrome, but it is also called shoulder non-specific shoulder pain based on some of the studies. So shoulder impingement syndrome is the problem due to the reduced space here, and that can happen when there is repetitive overhead above shoulder activities involved. That may also happen as a result of injury like fall. And usually it starts with the bursitis and then progress to supraspinatus, tendonitis, and tear, depending on the duration or symptom. So in the Rose situation, the tear doesn't happen overnight or even over 2 weeks. It may happen gradually built up over her working lifespan. And it can present with anterior shoulder pain or the lateral arm pain and usually get worse at night time. In terms of examination, there is a limitation of varying degree in the flexion and the abduction department, and internal rotation can be painful. The other condition we need to look at is bicipital tendonitis. This is not as common. In fact, most of the injury we will see would be one of the condition under the shoulder impingement syndrome spectrum. If adhesive capsulitis or frozen shoulder can also present with restriction of movement pain, and we may see them when someone had a long-term problem with the shoulder and then develop frozen shoulder over the time. The main treatment for that is that intra-articular injection with either steroid or saline that usually help with gentle manipulation. The final differential we need to consider is called a slap tear. So it is a superior labral injury that is extending from the anterior front to the back, hence it is called slap, and that usually attachment of the long head of bicep tendon. This is something that you will find on the MRI scans most likely, and it can be seen with other conditions. So this may not be a single isolated condition that you will find. In terms of investigation, David commented that if we can start with X-ray. If we have suspicion for any pathology, MRI is gold standard. With the test of the investigation, that need to be something that will influence our management. If it is not useful, it is not going to change the management, it is better to wait and not do that. If we do this scan, we need to do pre-test counseling on potential abnormal findings, especially when we are dealing with anyone older than the young workers. If we do that, it is important to know whether findings are the result of or the cause for the symptom that we are managing. So physical therapies, we recommended that we spend time with, we have to know in detail what type of physical therapies are available for at least at least for the shoulder impingement syndrome. Most of the time it is muscle strengthening, and in terms of to improve flexibility, that is the main thing for that. So yeah, he recommended that us to spend some time with physio if we do not know exactly what does that involve. If the physio alone doesn't helpful, we can also consider medication like corticosteroid. Corticosteroids are useful to reduce inflammation, and it can help with improving the compliance with the physical therapies. And surgical intervention are regarded as the last, and it is important to counsel people that surgery is only for severe and persistent cases, and that doesn't, it is not usually had better outcome than conservative management that need to be counseled, and we have to focus the shoulder function as the target of the treatment rather than presence or absence of pain. With the shoulder, we have generally two procedures. One is that decompression of the subacromial space through arthroscopy, or we do the shoulder reconstruction with rotator cuff repair. Shoulder rotator cuff repair. When we do that, it can be outcome and the duration of recovery will depend on many factors. This is the estimated duration of recovery from different procedures, and it would be relatively optimistic considering many of them have very short duration of downtime. Alright, so after that we also need to answer about hazard identification. With the shoulder problem, physical, ergonomic, and psychosocial hazards are the key one, and we have to answer site visit. Otherwise, how would we know these hazards are there? We also need to review job dictionary or job analysis. They are usually available, and we should ask for all the workers with the injury in the clinic. And we need to know which particular work activities in the physical and ergonomic are causing shoulder problem. Common usual suspects are repetitive overhead tasks, so that will be pushing, pulling, pushing trolleys, and also heavy lifting. Sometimes it is the speed that you need to keep up with the pressure, need to keep up with the job rather than the heavy load itself. One thing I haven't included here is that the effects of vibration onto the shoulder pathology. And this cover a similar problem as we mentioned in the previous slide. So we know the hazard, so we have to consider how do we deal with the hazard management. If we can eliminate that altogether, that will be awesome. If we can't, we have to do engineering and substitution. In terms of ergonomic assessment and adjustment, they are not strong in terms of effectiveness. In fact, there is very little evidence that they work. And to use the mechanical lifting is that's very sensible for most physical manual labor to minimize effect to the shoulder, not just to the shoulder, for the lower back as well. Task redesigns are important that will allow to reduce the load, rest, and other aspects of work safety. Afterwards, we need to look at administrative intervention. Now, this is like manual handling technique and lifting technique. They are the least effective compared to other measures, but we have to mention that in the exam, and that's important to acknowledge that. Other points that he mentioned during the talk is that when we are doing physical examination, it is good to use diagram and document that. It is better and more descriptive than just writing the finding on the physical examination. And in the exam, if you are not sure, we just need to say that we are not sure. He recommended not to make up stuff, and then that will waste your time, and that's gonna annoy the examiner. It is important to know our own limitation in terms of the medical history with the shoulder. Diabetes history is important. Yeah, I think that's all.